Hi, it's Jenny B, NSWOC. Today I want to talk about osteomyelitis. Now, osteomyelitis is bone infection that occurs in patients most often with diabetic foot ulcers, but also large pressure injuries that we see in the coccyx or anywhere that there's really a bony prominence and we're actually probing to bone. I've been very lucky to have the opportunity in the last several years to work with an orthopedic surgeon that we have developed really a recipe or an order set that we use to actually treat it. There's lots of other discussion out there about how we're actually treating osteomyelitis with antibiotics, whether we're using oral or we're using IV. And I want to kind of show you the difference between when we are starting with oral or we are switching over to IV, and why it makes a difference, and how we're able to do some limb salvage just by treating effectively and right away. So again, one of the very first things that we're going to do as a diagnostic is an x-ray. If you're actually seeing erosive changes on an x-ray to the bone in any area, that's a great indication that you actually have a late sign of osteomyelitis. Usually those erosive changes have taken place over a long period of time, and especially if someone's neuropathic or they have no sensation to the limb or to the toes or wherever you're finding this on the foot, they actually aren't even aware. I've seen lots of patients that have kind of walked a hole through their foot and they're not even aware that they've done so, other than they have maybe a little bit of bleeding. They think they've got a blister. So an x-ray is always a great place to start. Also, it can be used when we're doing other testing as a comparison to that. So again, start with the x-ray. It's super cheap. It's like 25 bucks. And we can use that. So again, if you're not seeing an open wound at all, we actually then is really our criteria to consider oral treatment first. If we just have some potentially erosive changes on x-ray, we have some edema localized, some erythema, those wounds we often will start with an oral treatment. We also tend to use oral Septra. Oral Septra is one of the most marrow sensitive antibiotics, so that the bone actually absorbs more of it. I know there's lots of different antibiotics that we can use. Sometimes we are basing them on swabs. Again, if there's no open wound, you really can't. But we've had great success with the use of oral Septra to treat osteomyelitis for, again, a minimum of 6 weeks. So we can go further on to up to 12 if we need to. It really depends on how extensive the osteomyelitis is, but I will show you some photos to kind of differentiate between the two. So again, when we do have it suspected, if the x-ray is clear, but we still clinically see signs of, again, there potentially, if there is a wound, if there is redness or erythema, some smell or something coming out of the wound, or that we have probed to bone. Again, once we've probed to bone, we treat it as osteomyelitis. We don't end up doing further testing because we know that 90% of the time there is osteo, so why not treat it? But if you're unsure, one of the easiest tests or the fastest tests to do is a site-specific gallium scan. So in the area of, say, your left foot, we're going to do a site-specific gallium and bone scan. So it's a 2-part series that they come over 2 days, and they have a dye injected and pictures taken, and they come back a couple days later, have more dye and more pictures. That can actually really tell us if that is something that we need to be treating or concerned about. And again, it's one of our primary diagnostics. The accuracy is about 80% of the time, but it's the fastest test that we can do here in good old Canada. There is, MRI is still the gold standard, or potentially a bone biopsy. We tend not to do a bone biopsy, mainly due to the trauma that can occur. And again, that's usually just trying to determine antibiotics, but with the recipe, we seem to have just as much success without having to do that or cause that trauma than if we did that. So MRIs, again, because they're so difficult to access, because it can be up to 3 months before they're even assessed to get an MRI, it's really going to delay the treatment, and we are looking at limb salvage, so we don't want to delay it any further. A white cell scan can be considered, especially if they have hardware in the area and they're not able to have the gallium. So it is another test, does have a slight delay, but at the same time, it can be very, very effective. Okay. So again, these are the types of wounds that I'm saying that if they're closed, that we would definitely start with an oral antibiotic treatment. If we've seen in this one, the x-ray, there is actually a small erosion on the tuft or the distal phalanx, and we were able to treat this with 6 weeks of oral Septra, 1 tablet PO BID. You can go up to 2 if you're seeing something, where it's even enlarged a little bit further, a little bit more erythema. But again, we also want to consider their kidney function, because again, if their EGFR is under 30, you actually need to consider use of single strength Septra. Some of the other key cautions with Septra is, 1, if they are on an ACE inhibitor, any PRIL, any medication ending in that term, they do need to discontinue that for the course of the treatment, because it can cause elevations in the medication, as well as it can cause elevations in their potassium. So usually we're actually doing a potassium check about midway through to ensure that hasn't elevated during the therapy. So again, these are other toes. Even when you have a slight wound, these are ones that, yes, we still would be using Septra. Same with this one here, but because we do have that edema and that change in it, and again, if there is erosive changes or not, we are opting for the oral Septra route. Again, here's some other cases. So this one we actually did use oral, and we did end up having to switch to intravenous. But again, we still started with trying oral. It just, we weren't seeing improvement after a couple of weeks, because we do reassess these every 2 weeks just to ensure that, the treatment therapy is working or effective. This is actually a scalp that I wanted to show, because it's not all feet that we're looking at that we do see exposed bone. So we do know that there is likely osteo within this, because the bone is exposed, and we actually have chips that are coming off of it as well. So again, this is one that we use some oral treatment, but we kind of did it to chronically suppress, which I'll talk a little bit more about further on. So again, this is another one here where this is a chronic bone that's out of this wound. So this patient actually had an amputation on the opposite leg, and it was truly going to affect his mobility if he had an amputation to this leg as well. So again, he had intermittent courses of what we use, actually at that time we used doxycycline for chronic suppressive disease. So this bone lasted in this state in the wound for over 4 years before he actually required any interventions. So again, it is another treatment that we will use if the Septra is not always ideal, especially due to renal function or if they're dialyzed, that we can use. So it is another option that we will consider chronic suppressive therapy when there is exposed bone, but lid salvage is really the goal. So this patient too has a Charcot foot, very common in about 25% of diabetic patients, where they have midfoot collapse, that the bones actually fall and create this rocker foot where there's a prominence in the midfoot. And again, this is something that we did end up using oral Septra with, because it was a very small wound, but again, it did probe to bone, and we were actually quite successful with just using the oral route. So indications for antibiotic therapy. So number one, I always actually like to show this photo, because this is actually a photo of extravasation. So it's when a certain vesicant or different types of IV medications have actually leaked into the tissue. So this is actually a patient's arm, and the IV site after vancomycin had actually leaked into the tissues. So this is why there's actually quite a big protocol with the use of vancomycin. But when we get into the IV therapies, it is one of them that we have to actually consider when a patient does have methicillin-resistant Staph aureus or MRSA. So again, our very first line of defense that we tend to use with intravenous antibiotics is IV Ancef or IV cefazolin. We're using 2 grams TID for 42 days. If there is the need for gram-negative coverage, because they may have a combination of Staph aureus and Pseudomonas in the wound, we actually will add an additional PO Cipro for 14 days to that. Cipro has the same bioavailability orally, it does IV, so we don't need to get a double lumen pick, but we can just give them the oral route so that they still can just have a single lumen and continue on with IV Ancef. Again, so then our next line of therapy is if we are swabbing and testing that there is MRSA within the wound, then our answer is vancomycin. Vancomycin we do give at 1 gram BID into a PICC line if possible. A lot of facilities are actually starting to put those in, and this is actually one of the reasons why, so that we're not ending up with extravasation and an additional wound to the one they already have that we're trying to treat. So vancomycin will require a trough level 30 minutes prior to the 5th dose, as well as lab work for weekly troughs to have prior to their dose. It doesn't have to be the 5th one, just weekly, as well as creatinine, just to ensure that it's not affecting their kidney function. Our trough levels we're looking at to aim for about 15. So, you know, the range, I believe, in the lab test will say from 10 to 20, so we really don't want to go over that, but, you know, we're really looking at to keep it around 15, and we will adjust by 250 milligrams depending on where their trough level is, sometimes omitting those doses. The last line of defense we tend to use is piptazicin. Not because, you know, it's a great drug and it's very broad spectrum, but again, we tend to reserve it for when there is lots of both gram-negative and gram-positive bacteria within the wound, but we don't go right to it. We find that the ANSEF is just enough, and because, again, ANSEF is actually extremely marrow-sensitive as a cephalosporin, it does very well to treat it without having to go into some of the larger drugs. So piptazicin, again, we will use 3.375 or 4.5 grams depending on the dose, QID for 42 days. So that's basically our recipe on how we use it, and kind of determine which one we're going to use based on you know, what we're seeing. So again, the difference between IV ANSEF and piptazo, we're always going to start with ANSEF, and then if we're not seeing any results, then we will potentially switch over to piptazicin, and then always vancomycin if we are seeing MRSA within the wound. So these are definitely some wounds where we do use IV. We go straight to it. We don't use the oral route, mainly because of bone exposure. So again, when we're seeing a lot of slough and the wound is probing right to the bone, we want to be aggressive at trying to treat this so that we do have, you know, success with preventing any amputation or surgical intervention having to occur. Again, both of these are, now this one we actually did oral to start, but it did not work. We went to IV, and we actually did eventually consider just taking the tip of the toe because of the way it was pointing downwards and where all the pressure was going, and that was actually a really good solution for this patient, because then pressure actually redistributed amongst the rest of the toes and prevented any further complications or further pressure injuries from occurring. This one again, when we've got some slough and we've got some debris, and we actually have bone spitting out from it because as it breaks off of the joints, it you know, we went straight to IV because of the swelling as well of the toe. And also when we're seeing the wounds where we've got 2 wounds and it's going right through, those are also a really great indication that we want to be aggressive in our treatment and use some intravenous antibiotics. This wound here did probe to bone as well, and responded really well to the IV. Now, I draw your attention to this one because there is some vascular injury in it as well, so, or vasculopathy. Sometimes the diabetic foot ulcers do have that combination of actually poor circulation or poor blood flow as well, and then osteomyelitis is kind of related to that. So we do have to consider, sometimes we're actually treating the osteomyelitis in order to await vascular intervention so that we can get better blood flow and then potentially heal the wound. So again, those ones often do require broad spectrum antibiotics so that we can treat all the bacteria, because when there's necrosis present, there's all sorts. Now, I didn't want to keep it just to feet, so into bottoms as well. So this wound, actually, the patient, the osteomyelitis was so extensive that it caused the coccyx to break off. So it was actually spitting bone. So again, this was one that we did go right to piptazicin after a short course of ANSEF not being overly effective to treat the osteomyelitis, and we did eventually end up healing it. Now, this was another wound which it's actually related to hidradenitis that is caused. So there's multiple abscesses that were in here, but it did end up probing to bone. So this patient did, because of the hidradenitis being a chronic condition as well, required long-term therapy. So we did keep them on doxycycline as a chronic suppressive to aid with the abscesses as well as treat the ongoing osteomyelitis that was in the bone. Now, there are a couple other things that are reasons why we do get osteomyelitis. Now, well, number one is hardware. So when you see a lovely incision line and then a nice little round dot on top of it, usually that's a good indication that if there was hardware that was placed because of a fracture, that there's a screw coming out of the plate, and with that exposure of the screw, there's likely infection into the bone. So these are ones that we will actually treat aggressively with IV antibiotics, so that we are able then to surgically manage, perhaps remove the plate, remove the cause of the osteomyelitis, so that it isn't something that becomes chronic for the patient. Another is gout. Infected gout can often be seen on x-ray as well, and I can't really differentiate between, is it infected osteomyelitis, is infection in the bone, or is it the gout itself? Because the tophi are really latched on, we really would treat it just the same. So depending on the severity, with this being open and you're actually seeing tophi out, we would treat it with intravenous to help reduce the swelling, not just an oral antibiotic. So here's a couple other lovely situations where, you know, when you don't quite know. This was actually a cold injury. This gentleman has neuropathy due to diabetes and had been out, you know, in minus 40 weather and didn't actually notice, you know, that he'd had some poor circulation to his feet. So the toes actually eventually became necrotic. We did actually require amputation because it did not respond to the intravenous antibiotic, and it was due to the ischemia from the cold injury. So again, this is one that we did try to treat aggressively with IV antibiotics, but it didn't quite work. This is another great example of the gout when you are seeing tophi actually come out of a wound that, you know, does get misconstrued sometimes. Oh, this could be a vascular, this could be you know, diabetic. It actually is gout when you're actually seeing that white cottage cheese like tissue come out of the wound. That we would still treat this as a septic gout, which is, again, the treatment is quite similar to, or it is similar, that's what we're using, is for osteomyelitis. And these lovely wounds are usually related to pressure, but again, combined with the fact that they're diabetic and neuropathic, that they're not actually feeling that they've caused erosion to the area. So this one, because it was so wet and draining so much, we actually have exposed tendon here, and it did, you know, the bone was pretty close underneath. We did end up actually treating this with IV antibiotics to get it closed, because you know, he does have a web here as well where they're attached. It's hard to differentiate where this was, but this is actually where the bone was exposed in between the two. So again, another great example of when to use intravenous. Now with this because it was probing to bone in two different areas and we could see it on x-ray, we did, because, and knowing that it was a later sign, we did treat that as well with IV ANSAF. So that's our recipe on osteomyelitis. Hopefully you found it helpful. There are lots of other tips and tricks that I have in my wound care for the emergency physician. So if you're looking for other quick fixes on and to understand what you can do to just treat things right away when you are seeing them, as well as some background with it, have a link. The link below is on my website, and you'll be able to find that material available for purchase, so that you have a great little guide to just walk you through, what you're seeing and then treatment for it. All right, have a great day. Don't forget, best wound is a closed one.